I sort of ended on this theme of direct oral anticoagulants being a good thing for us to think about. And Jean Connors is a good person to talk to us about that good thing. She's one of our really great supporters of the North American Thrombosis Forum, a great colleague in hematology. When I have tough blood clotting or bleeding questions, I turn to Jean, and she's going to talk to us about the blessing and the curse of direct oral anticoagulants. What do you do when actually patients develop bleeding in the setting of a DOAC? Jean.
Thank you, Greg. I'm delighted to be here tonight. I'm really going to talk about the curse of direct oral anticoagulants. And I've included a lot of information in the handouts. Mostly, some of it towards the end is more for your information. I've included guidelines. I'm not going to cover those, but I'm happy to discuss those during the question and answer session. So I'm going to briefly review these learning objectives, which I was asked to include, that include the following. Determine when to use DOAC reversal agents, and I think that that is probably the biggest question that emergency room physicians and ICU and in-hospital people face when somebody's on a DOAC and has bleeding. I'm going to compare the difference in the dosing strategies that we have for our reversal agents, have people recognize, I was told not to use appreciate, I think that's not a great active word, recognize the limitations of reversal agents and examine the knowledge gaps that we actually have for the existing data. You have to remember that DOACs really just came on the market in the last 5 to 10 years. And so our experience with them is growing without a doubt. But reversal agents are just new to the game, and there's still a lot of data that we need to learn and to explore. So DOAC are good. You heard Christian discuss DOAC. You heard Greg discuss the pitfalls of warfarin. But when we look at studies and we look at results, DOAC, we can say, are at least non-inferior in efficacy overall, no matter what indication you're using them for, whether it's AFib or VTE prophylaxis. So they're non-inferior or even better to warfarin in many situations, and they have decreased rates of bleeding. There was an interesting retrospective cohort study of ICH in like 65,000 hospitalized patients published in JAMA 2018 last year. And when you looked at the in-hospital mortality associated with ICH, warfarin-treated patients had higher in-hospital mortality than patients on DOAC. What I found very interesting about this study, and I encourage you to read it, is that 80% of the patients presenting to a hospital with ICH were not on an anticoagulant. They may have been on aspirin, but they were not on warfarin or DOACs. Both major bleeding and fatal bleeding are lower with DOACs, and the case fatality rate is lower with DOAC-related bleeding compared to VKA, even in the era when there were no reversal agents available. So if you have a patient and they're on a DOAC, and they have DOAC-related bleeding, you need to approach them like you would approach any patient. And we tell our emergency room staff, not to immediately jump to reversal agents. Stop the anticoagulant and make sure that the anticoagulant is stopped. I've used this slide for 6 years. I can tell you that even 5, 4, maybe even 3 years ago, a lot of different provider services weren't really familiar with what the non-brand names of the DOACs are. So when you've got somebody on rivaroxaban, sometimes the surgical service wouldn't realize that that was an anticoagulant, and those orders would be carried forward while they're in the hospital. Assess the severity of bleeding. If you're presenting with a patient, assess baseline coag tests, their CBC and creatinine, so that you can use those as a reference. But the thing about DOACs to remember is that they have a short half-life compared to warfarin. So if you look at the half-lives of all the DOACs in people with normal renal function, and you said the half-lives are approximately 10 to 12 hours for all of them, with the exception of Betrixaban, you would be correct. And so if you can manage your patient by just simply withdrawing the blood, that may be the DOAC, that may be the best strategy. Also, standard supportive measures. You've got a GI bleeder, it makes sense to give IV fluid, to transfuse red cells. Localization and management of the bleeding site. Can you cauterize that gastric ulcer? Do you need to embolize the bronchial artery? Can you put direct pressure on a vessel or use surgical interventions are key to assess. And the biggest question, though, is do you really need to immediately reverse anticoagulation and the anticoagulant drug? And remember that in all the studies that have been performed to some degree, when we look at even reversing warfarin and getting that INR down into the target range, we can look at mortality rates, but we haven't really assessed how they impact other outcomes. So keep that in mind when we talk about the reversal agents for DOACs. I'm sorry. Idarucizumab. Idarucizumab is a monoclonal antibody that's humanized. It's a fragment. It has a short half-life. It binds to dabigatran with a 350-fold higher affinity for dabigatran than dabigatran has for thrombin. So it binds it rapidly and tightly in the circulation, and it's cleared through the kidneys. It was approved in 2015 in the US, in 2016 in Europe. All patients get a 5-gram IV bolus dose, whether they need it for emergency surgery because your patient presents with an acute abdomen and they're on dabigatran, or they have life-threatening or uncontrolled bleeding. The approval and the dosing strategy is based on the REVERSE-AD trial, in which they took 2 groups of patients who presented to emergency rooms, Group A, who had uncontrolled bleeding, and Group B, patients who required urgent surgery with a definition of within 2 hours. All patients got a dose of 5 grams of idarucizumab, and this dose was determined because it reversed up to the 99th percentile of the peak dabigatran levels in the RELY trial. So trying to capture all comers, no matter what their plasma dabigatran concentration was. Non-randomized study, okay, you'll be hearing this in the literature. I can discuss this during our Q&A session. No reversal agents for the DOACs have been studied in a randomized fashion. The full cohort analysis was finally published in 2017. 503 patients enrolled in this real-world study coming into emergency rooms all over the world. Overall, there was about a 7% thrombosis rate and 18 to 19% mortality, because these are very critically ill patients presenting to emergency rooms with ICH, GI bleed, pulmonary hemorrhage, or needs for surgery. When we look at the REVERSE-AD results in Group A, these are patients who presented and required and had major bleeding, and you give that 5-gram of idarucizumab bolus, and you're looking at the diluted thrombin time, a measurement of coagulation that's done in seconds, that's very, very exquisitely sensitive to the presence of dabigatran. You can see that after the 5-gram bolus dose, the diluted thrombin time drops down into the normal range and stays there for about 24 hours. And if you look at all of the types of bleeding, and we can slice and dice this in many different ways, but if you look at patients who did not have ICH, because ICH was not assessed in the idarucizumab trial. There was no mandated head CTs for patients who presented with ICH once they got dabigatran. So we don't know how well the idarucizumab worked to contain or control the ICH volume. But when we look at this, in the accessible GI, soft tissue, retroperitoneal bleeds, it was deemed by the investigators on site that the median time to bleeding cessation was about 2.5 hours. When we looked at Group B, those patients requiring urgent surgery, which is a lower total number of patients here, 195 patients out of the 500, the surgeons were very, very happy. Whoops. And you can see that 93% of them thought that there was great reversal. So these are patients who came in, they weren't bleeding, they got idarucizumab because they needed to go rapidly to the OR. Indexanthe Alpha. Indexanthe Alpha is a marvel of recombinant technology. So Indexanthe Alpha is the reversal agent for 10A inhibitors, the 10A inhibiting DOACs, which includes apixaban, edoxaban, rivaroxaban, petrixaban, but it also works for those 10A inhibitors that work through antithrombin. So there are data that demonstrate that Indexanthe works to reverse the anticoagulant effect of low molecular weight heparin and fondaparinux. What is it? It's a decoy factor 10 molecule. Sorry, I keep hitting the wrong button here. This is the native factor 10. This is the active site of factor 10, which cleaves prothrombin to thrombin. This is the GLA residue. Us hematologists love to go on and on about how coagulation works in the coagulation cascade, but I'll spare you. Basically, the Indexanthe molecule has a mutation so that it can't cleave prothrombin to thrombin, and it lacks this GLA domain, so it can't incorporate into other coagulation pathways. It is a universal factor Xa inhibitor antidote. It was FDA approved in May 2018 for apixaban and rivaroxaban patients on apixaban and rivaroxaban who have life-threatening bleeding. And this is because there were the most data for these two DOACs and not a lot of data for edoxaban. Edoxaban wasn't really on the market at the time, nor was betrixaban. And I think there were a total of 16 patients on enoxaparin with the data submitted to the FDA, which was felt to be insufficient. So I'm showing you the curves of Annexa A and Annexa R. These are trials in healthy volunteers who are given Indexanthe after they've reached steady state with apixaban or rivaroxaban. And you can see in the top panels are apixaban, rivaroxaban after getting an Indexanthe bolus. And then we have apixaban and Indexanthe bolus plus a 2-hour continuous infusion. So if you remember the previous slide, the Indexanthe is a very, very tiny molecule. So it has a very short half-life in the circulation. And so you can see in panel C and panel D that patients who have an anti-factor Xa activity measured in nanograms per mil of apixaban or rivaroxaban have a dramatic drop upon receiving the bolus infusion of Indexanthe, and this is sustained during the continuous infusion, but after the continuous infusion is stopped, there is an increase in the anti-factor Xa activity or the plasma drug concentration back to where they would be had they not received the Indexanthe. And this is because the DOACs are also very small molecules and they widely equilibrate in the intravascular and extravascular space. And some of them, particularly rivaroxaban, have a very high volume of distribution, up to 60 liters. The Annexa 4 is the real-world trial design. This is the design of the trial. Patients are identified, and if they took a Xa inhibiting DOAC within 18 hours, they were placed on the trial and received Indexanthe, either one of two doses, which I'll show you. The primary efficacy measurements for the outcomes were two. One was % change in factor Xa activity, and one was hemostatic efficacy assessed at 12 hours by the investigators. The final report of the Indexanthe trial in the real world was just published this spring, 2019, actually January. 352 patients enrolled, a 10% overall thrombosis rate, and 14% mortality. This is the Indexanthe dosing scheme. It differs based on whether you took apixaban or rivaroxaban and when you took rivaroxaban. You either get standard dose or a high dose. When we look at the Annexa 4 results, again, these are now the real-world results of patients enrolled in the trial. You can see, again, anti-factor Xa activities in nanograms per mil on the y-axis. Patients get the bolus and then the 2-hour continuous infusion. You can see a significant drop in the concentration of either rivaroxaban, which is sustained for 4 hours, or apixaban here. The co-primary endpoint, this was one of the outcomes, 92% of patients had an appropriate drop in anticoagulant activity. Hemostatic efficacy judged by the treating clinicians, the investigators on site, were deemed excellent or good in overall 83% of patients and composite 82%. But no matter how you divide up the patients receiving the drug, you can see that overall hemostasis was considered good to excellent. So here is the summary of the results. The co-primary endpoint, the proportion of patients with excellent or good hemostasis 12 hours later, overall 82%. Well, how does this break down? And there were 60% of the patients in this trial had ICH. Very different from the dabigatran trial, which had the cohort of surgical patients as well. So in this trial, 80% excellent or good efficacy in ICH, measured by post-Indexanthe CT scans and volume expansion. So it's a very rigorous trial. This was not done with idarucizumab, and we've never done this with 4-factor PCC when we're reversing warfarin. GI bleeding, a little bit better at 85% efficacy, excellent or good. Again, thromboembolic events. And some of the thromboembolic events are simply, as you've heard from Greg, not restarting anticoagulation. So the last thing I want to cover in however many minutes I have left is the issue of whether or not 4-factor PCC works to reverse 10A inhibitors. And one of the reasons I had that asterisk in my slide about FDA approval of andexanet is the approval to reverse apixaban or rivaroxaban was contingent on the company doing a randomized controlled trial of andexanet versus standard of care. So in many institutions, 4-factor PCC is viewed as standard of care. So does it really work to reverse 10AI? 2 recent studies published in the last year and a half, 2 years, in healthy volunteers given DOACs. You can see that apixaban in this trial, 2 different brands of 4-factor PCC, reversed the lab tests for coagulation. So we had normalization of coagulation. And placebo did nothing in this trial and the 4-factor PCC did nothing to change the plasma drug concentration. So a little different from andexanet, which dropped the plasma drug concentration. Levy added to this using rivaroxaban and prothrombin complex concentrate, or TXA as kind of an active control. The 4-factor PCC reversed the lab tests and restored thrombin generation, and TXA did not. But interestingly, Levy did punch biopsies on these volunteers, and there was no effect on the punch biopsy bleeding volume in people who got 4-factor PCCs. A real-world study published in 2017 looking at 83 patients who presented to emergency rooms in the Netherlands, and they had GI bleeding or ICH, and they were on a 10A inhibitor. They got roughly 2,000 units of 4-factor PCC, and in this sort of prospective observational study, approximately 72% of the patients on apixaban, 73% on rivaroxaban who had ICH were felt by the investigators to have effective reversal, a little bit lower in the GI bleeders. 32% mortality. Again, these are very sick patients that we see in the real world when they present with bleeding. And so I'm going to summarize the 4-factor PCC data with a quote from this meta-analysis that was published in January 2019. And it was a meta-analysis of all the data out there using PCC in patients taking 10A inhibitors who present with bleeding. And as you can read, on the basis of evidence with very low certainty from single-arm case series, it is difficult to determine whether 4-factor PCC, in addition to cessation of the direct oral factor 10A inhibitor, is more effective than simple cessation of the direct factor 10A inhibitor alone when they have direct factor 10A inhibitor-related major bleeding. And so the story is not finished with regard to the role of 4-factor PCC in reversing 10A inhibitor bleeding. These are the approval status of all of these compounds, which you can read. This is from the American College of Cardiology, published December 2017. This is the guidelines, and I'll have you read them. If you notice, ACC for first-line reversal for these drugs use the specific reversal agent as first line. So dabigatran, idarucizumab, for apixaban and rivaroxaban, andexanet. Similarly, European Heart Rhythm Society published guidelines. They're waiting for Indexanthe in Europe. So my last slide, how do we use these antidotes? We really reserve them for patients who have life-threatening bleeding, not the nosebleed, not the hemoglobin drop in the GI bleeder who's doesn't have hemodynamic instability and hasn't had a big crit drop, patients who have intracranial hemorrhage, people who have critical organ bleeding, such in the eye, or large RP bleeds, or massive hemorrhage. Bleeding in the setting of delayed renal clearance. So some of the worst bleeding events I've seen are in elderly patients who have unexpected decline in renal function, and sometimes abruptly. They have nausea, vomiting, diarrhea, GI illness. Their creatinine clearance goes from 50 below 30, and they have bleeding because of increased plasma concentration of drug. And I'll end with these current questions that we can discuss in the Q&A session. Do they really work? Do we need randomized controlled trials? What about the cost, which I'm not going to discuss right now? And should your institution add reversal agents to formulary? Thank you.